Hi, I'm John Harrison, consultant surgeon and endoscopy lead at Harrogate NHS Foundation Trust, and this video is going to be about the insertion of a Sengstaken tube or a Danis stent in the event of the standard treatment of banding being unsuccessful with ongoing hemorrhage despite your best attempts. So basically, in the situation where banding or injection of sclerotherapy agents has been unsuccessful, you need to pivot to making the decision to insert a tamponade balloon. There's various types of these. Particularly the Linton necklace tube, which has just a gastric balloon, and the Sengstaken Blakemore or Minnesota tube, two separate ones, which also have an esophageal component. The one probably in most common use in the UK at least is the Sengstaken Blakemore tube, and that's what I'll be talking about. So you get your tube, which is mainly 16, 18 or 20 French diameter, and you choose the size of the tube depending on the size of your patient. So you insert the tube with with some lubrication and put it down into the stomach. Now, in some cases, some people are willing to inflate the tube without doing it under direct vision, but cases have been reported where the tube didn't get down into the stomach, and it was inflated in the esophagus with you can imagine not very satisfactory outcomes. So what I do is to put the scope in next to the Sengstaken tube and watch it inflate under direct vision so that you can see that it's in the stomach. So you put 300 mils of air into the gastric balloon and then pull back until it's pulling on the gastroesophageal junction. And having done that, you then attach a litre bag of fluid to the Sengstaken tube and maintain traction there for usually 48 to 72 hours, during which time the patient is stabilised on the ITU. You usually do the procedure under general anaesthesia in these patients anyway, but if you've started without a general anaesthetic, you'll end up with a general anaesthetic for the patient, so that they go to the ITU and spend the 48 to 72 hours, as I said, to get stabilised, and then you take them back to theatre and deflate the balloon, and by which time everything will have settled down, usually anyway, and you can then put some more bands on that as appropriate, and hopefully it will then be satisfactory. One thing I would guard against is not using the esophageal balloon unless you're in really dire straits, because it can be very difficult to judge the right pressure, and it's relatively easy to cause esophageal necrosis due to pressure. So we tend not to use the esophageal balloon and just rely on the pressure of the gastric balloon on the coronary veins where the anastomosis between these veins and the portal system occurs, and that shuts off the bleeding very successfully. Recently, there has been an innovation in the management of patients where primary treatment with banding or injection has not been successful, and this is with insertion of what is known as a Danis stent, and this is a relatively new innovation, and it can be inserted in a very straightforward manner, and a video animation of this will follow. It is recommended by NICE as an alternative to balloon tamponade, and it has the advantage of not requiring intubation, so the patient doesn't have to spend any time on the ITU usually, unless they're unstable for other reasons. So the stent is inserted, and the animation will now follow. And now we will go on to the nursing aspects of the procedure, and these will be described by Bernice. Over to.
Okay, so we are going to present to you how to prepare the Sengstaken tube. We go through this method once we filled with the banding of the varices, esophageal varices. I could say it's like a last resort method we will need to use. Every time, always make sure once we get it out of the packet, inspect and check there is no leakage or there is no problem from manufacturing. Always check the expiry dates. They will come in 3 types. There is 16, 18, and 20 French. But the one which I'm using is 18 French. And the consultant normally would prefer to use 18 or 20. Post intubation, they will just let them know that they need a Sengstaken tube. Ensure before using all these clamps are in place. Follow that's it, the clamping. That is the idea initially. It's very good, this silicone. It's easy for insertion. We don't have to keep it in the fridge like with other Sengstaken tubes which were used in the past. Again, it has got a sponge which we use for patient comfort during traction, and that's okay. So I'm just going to continue. The main thing we need to remember prior is to make sure you locate the gastric balloon. It's so clear, it's in red. That shows you can never miss it even if it's in dark area. So you make sure that is the only balloon you're going to use for this. And then you can, if you have time, that depends if you have time, you can inflate maybe just 50 ml of air just to see that it will actually work. Because it will be a problem if it doesn't. Then you deflate that air. That is if you have time, because sometimes you don't even have time in great emergencies. So that's fine. And you will lubricate prior to insertion, and you need to make sure that the guide wire is at the tip for easy insertion. If not, it will just give it will be temperamental, and that will be frustrating for everyone in the procedure room. So that's what we'll go through. So normally the patients will be in theater. This can be done under general anesthesia. And then it goes through the mouth. Some people they will say through the nose, but for our trust, we always it will go through the mouth, all the way down, up to the point where it's inside the stomach area. That is the point where you will be asked to inflate. You will keep the syringe, catheter syringe, just on standby. Where there is a lot of blood, you may be asked to aspirate from this end. Then you find that you'll be aspirating some blood from there. So that's why it comes handy. So what do we need to remember? Once we are using the balloon, the red gastric balloon, we need to remember that we are going to inflate with 300 of air, not water. We will just demonstrate. This is the first 50. You need to be really loud so that everybody in the room will hear. That's first 50. Then now I will say 100. Then from there I will say 150. Then I'll go again and say 200. Then I'll continue. That will be 50. 250. Then you just say, this is the last syringe of 300 to make everybody aware that this is the end. You can no longer inflate. This will keep the pressure. Probably that is more like at the gastroesophageal junction. That pressure will actually constrict those bleeding esophageal varices. The more we apply the traction, and I'm going to show you how we'll apply the traction. We will use 1 liter of saline. We'll connect it to the pole and the aftercare in ICU, where they will be able to see to it that the patient is well looked after. That will give enough traction to hold on, and you need to remember that after 48 hours, the balloon will be deflated. Then the monitoring will be continuous by the consultants and the staff in ITU. I think that will be all right now. So what I need to remind you is the part which I will not show you now is to deflate, because normally it will be done in ICU. But ideally, the opposite is just to draw all this air that you introduced. You'll did 50. That's it. Then we go again, 50. That's okay. That's 100 gone. Another 50. That's 150. Then we'll continue with another 50. That's 200. Another 50. Then the last 50. We need to make sure there is no more air. Completely, I feel resistance. Then you are sure that it's ready to be removed. Just be mindful that when you introduce the Sengstaken tube, the consultant will let you know that later on you may need to pull back the stylet, because we only need the stylet during the insertion process. Once that's done, then it's up to the endoscopist when they would like you to remove the stylet. I think that's the end of the presentation. Thank you, everyone.
Okay, so that's the end of our video looking at the insertion of a Sengstaken Blakemore tube or stenting for esophageal varices not controlled by primary treatment with banding or injection, and I hope you found it helpful and informative. Thank you.